Good day to everyone. My name is Lex Vincent ABAYAN, nursing student. I'm here to report about the total laryngectomy. Total laryngectomy is the surgical procedure in which the larynx is totally removed and the airway is interrupted, respiration being performed through a tracheal stoma, resulting from bringing the trachea to the skin in the lower anterior cervical area.
Surgical deconstruction. A U-shaped incision is made and the visor of skin lifted. The sternocleidomastoids are retracted laterally. Once the strap muscles are raised, thyropharyngeus and cricopharyngeus are revealed and shaved off their respective cartilages. The suprahyoids and middle constrictor are dissected off the hyoid, revealing the pharyngeal mucosa. The hyoid bone is depressed and the pharynx entered from above the epiglottis. The trachea is divided below the second tracheal ring. The larynx is separated from all its attachments and removed, leaving an open pharynx. The endotracheal tube is transferred into the tracheal stump for ongoing respiration.
Total laryngectomy is a surgical procedure that removes all of the voice box. This means that the airway or trachea is separate from the mouth, throat, and esophagus, and breathing occurs only through a stoma. A stoma is a hole in the front of the neck just above the breastbone. This hole directly connects to the trachea or windpipe. The stoma is the only route for breathing in a patient who has had a total laryngectomy. A patient with a total laryngectomy may or may not have tube in their stoma, which differs from a tracheostomy. This will be explained later on in a greater detail. A patient who has had a total laryngectomy is also known as a neck breather. This means they only breathe through the stoma in their neck. Their mouth and throat are connected only to the esophagus. This is significant because intubation through the mouth will not work, and thus the stoma is the only route for both intubation and ventilation. Patients who have had a total laryngectomy may wear a medical alert bracelet that states that they are a neck breather. The photograph in the middle shows the appearance of a typical laryngectomy stoma. The diagram on the right has a blow arrow which designates the airflow pattern in a laryngectomy patient. The laryngectomy stoma does not require a tube, but they are often used. They are called Lary tubes. You may also see patients with heat and moisture exchangers or HMEs in place. An HME is a small filter device that overlies the stoma. Normally, the upper airways serve to warm, humidify, and filter air from the external environment. In total laryngectomy patients, the connection to the upper airway is lost, and thus the HME serves to replace those functions. This helps to prevent excessive mucus buildup crusting within the trachea. The photo on the left shows a completely open laryngectomy stoma. The photo in the middle shows a laryngectomy with a Lary tube in place. And finally, the photo on the right shows a laryngectomy with HME in place. It is important to note that a tracheostomy differs from a laryngectomy stoma in several ways. First and foremost, a patient with a tracheostomy still has a larynx for the voice box. This means that the patient still has a connection from the nose and mouth to the airway, and if necessary, they can be intubated from above. When managing a laryngectomy airway, the most important piece of information to remember is that the stoma cannot be covered at any time. If present, remove laryngectomy tube, base plates, or HME to completely expose the stoma. Providers should not try to cover the stoma with a dressing or try to intubate from above, because again, the stoma is the only source for ventilation and intubation. If the patient has a respiratory event requiring ventilator support, either an endotracheal tube or tracheostomy tube can be placed into laryngectomy stoma. The endotracheal tube will only have to be placed in a short distance before reaching the carina because laryngectomy stomas are larger than trach stoma. A cuff trach tube can easily be placed into the laryngectomy stoma. It can be secured with regular track ties around the patient's neck. If intubation or ventilation through the stoma is unsuccessful, consider a tracheal obstruction. It is not uncommon for obstructive crust to form within the airway or within the stoma itself. Visible crust should be removed with forceps. If at any point there is a question or challenge, otolaryngology should be contacted immediately. If otolaryngology is unavailable, general surgery of your institution airway management should be consulted. It is also important to consider a pulmonary etiology, for example, comorbid COPD, as an etiology hypoxia in the patient. In regard to the current coronavirus pandemic, there is no definitive data on how to best care for and manage laryngectomy and tracheostomy patients. We do know that there is increasing evidence of asymptomatic transmission of the virus. We also know that laryngectomy and tracheostomy generate respiratory droplets. Thus, we do anticipate an increased risk of transmission to the providers who are taking care of laryngectomy and tracheostomy patients. We also anticipate increased risk of infection and serious illness with associated comorbidities in this patient population. When interacting with all patients, including those who are asymptomatic and low risk for having the virus, you should be wearing PPE. This may include a 95 mask, face shield, gown, gloves, and head cover. PAPR is preferred for patients who are deemed high risk if they are currently under investigation or known COVID positive. Other guidelines to follow when examining patients, including maintaining a closed examination space and covering open airways, including laryngectomy and tracheostomy. There are numbers of ways you can provide coverage over an open airway, and there are a variety of devices which can mitigate the risk of droplet and aerosol spread. For laryngectomy patients, this includes a Lary tube or adhesive base plate with HME. For tracheostomy patients, this includes a Pasmer valve or trach cap, track HME, inline suction and HME, or simply mask over the lumen. The Pasmer valve, HME, and adhesive base plates are shown in the figures on the right. For the conclusion, laryngectomy is done to treat cancer of the larynx. It is also done to treat severe trauma such as a gunshot wound or other injury, severe damage to the larynx from radiation treatment.